Record. All right. Good morning. Good afternoon, everyone. Thank you for being with us. My name is Dr. Carolyn Rowley, and I am the founder and executive director at Cayenne Wellness Center. Thank you for joining us. Today's mini seminar is the Brain and Sickle Cell Disease Part 3, Bringing Families and Schools Together. This mini seminar is sponsored in part by Global Blood Therapeutics and HRSA Grant. Our mission here at Cayenne Wellness Center is to increase the quality of life for individuals diagnosed with sickle cell disease in California by ensuring expert, unbiased, and comprehensive care. This mission is part of a broader vision of a medical system which effectively addresses the unique needs of individuals with sickle cell disease and patients who are empowered and equipped to advocate for themselves. I would like to bring to your attention some of the upcoming calendar of events. So upcoming for the remainder of May, June, and July, next week, Wednesday, we actually have an event called Let's Talk About Indari. And that's going to be on May 26th, Wednesday, 6:30 to 8 p.m. June 19th, you'll definitely want to hang out with us. This is going to be our second annual 24-hour Marathon World Sickle Cell Day in partnership with the Sickle Cell Community Consortium. So definitely, you may want to try to hang out with me. Yours truly will be up for 24 hours on World Sickle Cell Day, and we have quite a bit going on that day, in addition to movies and talks on men on sickle cell disease, dating, women, author's corner, and then of course our family feud sickle cell style. And so you'll definitely want to tune in for as long as you can. On June 26th, we'll hold our second Mental Health and Sickle Cell Disease Part 2 with the KIT, moderated by Dr. Jonah Saint with Lori Crosby as our speaker. On July 24th, we'll hold our second mini seminar on sleep and sickle cell disease. The first one was phenomenal. This part 2 is going to be looking at the adult perspective on sleep. And then on July 30th, we'll hold our second Arthur's Corner, this time focusing on helping adults live their best life, featuring Dr. Simone Uwan and Jennifer Fletcher. Our staff is Golda, our program director, who's actually on. If you want to say hello, Golda.
And hi guys, thanks for joining.
So she'll be helping with all things technical. She'll also be assisting with if you are putting your questions in the chat, she'll be minding the Q&A, and I'll be minding the chat. So you're welcome to either raise your hand so we can acknowledge you, put your question in the chat, and or the Q&A. And now I'd like to introduce you to our moderator for the Brain and Sickle Cell Disease series, the phenomenal Dr. Ebony Lance. Dr. Ebony Lance is the Associate Director of the Neurology and Neurogenics Clinic at Kennedy Prager Institute, neurologist and medical director of the Sickle Cell Neurodevelopmental Clinic, and an assistant professor in the Department of Neurology and Pediatrics at the Johns Hopkins School of Medicine. That's why I said she's phenomenal. Dr. Lance received her undergraduate degree from Princeton University and received her medical degree from the Medical University of South Carolina. She did residency in general pediatrics at Children's Hospital Los Angeles and additional specialized residency training in neurodevelopmental disabilities at the Kennedy Prager Institute. She received additional research training at Kennedy Prager Institute, Johns Hopkins University School of Medicine, and has a PhD in clinical investigation from the Johns Hopkins Bloomberg School of Public Health. Dr. Lance is board certified in general pediatrics, neurology with a special qualification in child neurology, and neurodevelopmental disabilities. Dr. Lance's research interest is in children with sickle cell disease and neurodevelopmental issues such as ADHD, intellectual disability, and learning disabilities. Dr. Lance will summarize parts 1 and 2 that we did in November of last year and earlier part of this year, followed by introducing our guest speakers. Dr. Lance?
Thank you so much for that kind introduction, Dr. Rowley. Very excited for our last seminar, and I am just going to share my screen. Oh, it's telling me I can't share my screen because someone else is sharing. Okay, great. Got it. And all right, everybody can see my slideshow. Okay, excellent. All right, so I don't have any relevant disclosures for this presentation. I'm not going to discuss anything unapproved. So just to recap some of the reasons behind this seminar, there are different types of brain injury in sickle cell disease where patients can have overt strokes, which is that very apparent stroke where you may have weakness on one side of your face or your body. You may have difficulty speaking or being understood. In addition to overt strokes, some patients can suffer from silent cerebral infarctions. It's actually the most common neurological complication of sickle cell disease, typically involving the smaller blood cells of the brain in the frontal and central lobe of the brain. And it happens in over 1/3 of patients with sickle cell disease before 14 years of age. The other issue with silent cerebral infarcts is that once you have one, that can put you at increased risk for having another one or for having an overt stroke. And then at the bottom of the pyramid, we actually see what I see most commonly in children with sickle cell disease in our clinic, and that's children with school problems and cognitive dysfunction. And we really think that that's happening because of suboptimal oxygen delivery in these patients, possibly as a complication of the disease process itself, because anemia means you may not have enough red blood cells getting to your brain, and the red blood cells hold the oxygen. So it's also important to note that brain injury in sickle cell disease is very selective. It very much targets the frontal lobe, as you can see from this slide from the silent cerebral infarct multicenter clinical trial. Of 286 patients with silent cerebral infarcts, 90% of those patients had infarcts in the frontal lobe of the brain. And that's something that becomes really important when you see all of the things that the frontal lobe is in control of. So the frontal lobe, most importantly here, controls your executive function. And that's really how you pull everything together. That involves thinking, planning, organizing and problem solving, emotional and behavioral control, and also some aspects of your personality. And to put it even more specifically, executive function has 3 components. It includes working memory, or being able to keep information in your mind and then use it in some way. Cognitive flexibility, or flexible thinking about something in more than one way. And then inhibitory control, or self-control, which is being able to ignore distractions and resist temptations. And because of these 3 aspects of executive function, people who have difficulties with executive function may have problems with paying attention, organizing and planning, initiating tasks and staying focused on them, regulating emotions, and self-monitoring. Now, some new guidelines have been released regarding sickle cell disease, both in general pediatrics as well as by hematologists. And so the general pediatric rules consider sickle cell disease to be a high-risk condition. And so that means it's something that your general pediatrician should be screening your child for in terms of looking for these developmental disabilities. And so again, high-risk conditions can include conditions associated with neurodevelopmental and behavioral conditions that affect early and long-term development and achievement, disorders with high rates of co-occurring developmental or behavioral disorders, and that's the heading that sickle cell disease fits under. and then children who are vulnerable to developmental and/or behavioral problems. And that may be due to the social determinants of health, as well as other adverse childhood or family experiences listed below. And so if your child meets any of these conditions, they really should be considered high risk and have a closer developmental evaluation. The sickle cell disease guidelines say similar things. So for children with sickle cell disease who have abnormal screening for developmental or cognitive issues, the American Society of Hematology Guideline Panel recommends that they receive a developmental, cognitive, and medical evaluation to diagnose related disorders and identify modifiable risk factors. And then after receiving those evaluations, we should really be following evidence-based guidelines for these conditions to provide appropriate interventions. And so that brings me to the summary for part one of our three-part mini-series. Part one was based on a neuropsychology perspective, and our speaker was Dr. Alicia Cannon, the neuropsychology director for the Kennedy Krieger Institute Sickle Cell Disease Neurodevelopmental Clinic. Dr. Cannon spoke about what is neuropsychology, which is the study of brain and behavior relationships. She noted that neuropsychologists have a PhD or PsyD in clinical psychology and are trained in neuroanatomy, neurophysiology, psychological assessment, and treatment. And as part of their evaluations, they integrate information from multiple sources, provide recommendations, and try to provide a relevant, concise, timely, and helpful report. The purpose of these evaluations is to better understand an individual and provide recommendations and really take a look at their cognitive strengths and weaknesses, behavioral strengths and areas of difficulty, assess for changes, have their symptoms improved, have they gotten worse, documenting a baseline neuropsychological status prior to some new treatment or intervention, determining the need for additional support or school services, helping with transition planning, and really pulling together the whole picture. In summary, the part one series, Dr. Cannon concluded that individuals with sickle cell disease are at increased risk for cognitive deficits in multiple domains, including attention, executive functioning, and processing speed. That is, again, in part because of that frontal lobe damage that is very targeted in sickle cell disease. She noted that cognitive deficits may have immediate and long-term consequences, impacting school performance, relationship with peers, and quality of life. And lastly, and importantly, she noted that just like medical status is monitored in patients with sickle cell disease, that cognitive and functioning and development should also be regularly assessed in these patients. Part two of our mini-series was looking at a psychology perspective. And so we had two talks, actually. Dr. Wendy Santos Modestit and Dr. Judy Cavazos, from UCSF Benioff Children's Hospital in Oakland, talked about how mood and thoughts can impact persons living with sickle cell disease. And then Dr. Geraldine Porter from St. Jude's Children's Research Hospital talked about minding the gap, transition to adult care in sickle cell disease. And so the first talk really focused on why mental health is important. And mental health includes emotional, psychological, and social well-being, affecting how we think, feel, and act, as well as how we cope with stress, relate to others, and make healthy choices. And so mental and physical health are thought to be important factors in overall health and well-being, this mind-body connection. So thoughts, feelings, beliefs, and attitudes can positively or negatively affect our functioning, and certain mental health conditions can increase the risk for many types of physical problems. In addition, the presence of chronic health conditions can increase the risk for mental illness. And so in addition, there's been some research showing that people who have depression and another medical illness may have more severe symptoms of both their depression and that other medical illness. And that is really important to consider with a disease like sickle cell disease, where the body is already impacted physically. Mental health conditions can exacerbate pain, possibly contributed to other pain episodes. So the role of behavioral health providers is really to provide direct clinical care to patients and their families, evaluate needs and recommendations, diagnose disorders, and then provide treatment. And that can be through talk therapy, helping patients learn coping skills such as pain management techniques, and really linking patients to services and providers. They also measure and monitor outcomes and can report back to the primary medical team and collaborate with the medical team as well as psychiatric providers, be the liaison. It really is important to have that model of team holistic care to improve outcomes. And so in summary for their talk, you are important, your mental health is important, your physical health is important, and treatment for the management of anxiety, depression, and other mental health illnesses can really help reduce physical related issues. The second talk from the last session really focused on transition to adult care for children and adolescents with sickle cell disease. And so these were some of the transition fears that were shared. Leaving trusted providers, mistrusting adult providers, access to care, learning about the adult healthcare system, lack of support and feeling unprepared, and really wanting to be like peers. And there were some special considerations when considering transition, one of which was that decreased cognitive function can negatively impact educational attainment and employment, health literacy, and coping and resilience. And again, that mental health issues such as depression can be linked with lower cognitive functioning as well as chronic pain, functional impairment, difficulties with social skills, and increased healthcare utilization. And so these are all things that might impact transition care. These were also some of the predictors of successful transition in patients, and that was self-efficacy, or really being able to take care of yourself, readiness for transition, adherence to a care plan, parental support in the process, model programs, and then a patient-centered medical home where really everything kind of surrounds the patient and kind of lifts them up to that next step. And there was also an action plan for transition provided where we discussed the typical ages for transition and what can start happening at those ages to really help the patient and the family transition smoothly to adult services. And so really revisiting these action plans year to year is something that can be helpful with that process. And so that brings me to our last seminar today, part 3, an educational perspective on the brain and sickle cell, school and sickle cell disease. Our first speaker is Aisha Gilliam. She is an educational liaison at the Washington University School of Medicine in St. Louis, Missouri. She holds a master's in education administration and counseling from Missouri Baptist University, as well as certifications in elementary and special education. She's a licensed professional counselor and works in private practice and has more than 10 years experience in the field of education, working to support students with special needs. Currently, she services pediatric patients with hematology needs in the area of sickle cell disease. She is passionate about helping bridge the gap between medical and school settings. Ms. Gilliam strives to empower her patients and families to advocate for their needs. Her goal is for her patients to be more competent in their academic abilities and helping schools to think outside of the box to service those with unique needs. Ms. Gilliam also supports patients with post-secondary transition. She developed partnerships with community stakeholders to help improve educational outcomes for the patients she serves, and she has been fortunate to see progress in the patients she has supported. She knows it takes a village and appreciates the continued support from her colleagues. Ms. Gilliam makes it a point to learn something from each family she encounters. Our second speaker today will be Dr. Latasha Hamilton. She has worked in education for over 20 years and joined St. Jude's Children's Research Hospital 11 years ago. As an academic coordinator, Dr. Hamilton has worked with patients ages 2 to 18 years, but primarily works with teams to advocate and provide sickle cell disease education to school professionals throughout Tennessee, Mississippi, and Arkansas. As part of a comprehensive transition program, she developed the academic vocational domain to prepare teens for transition to adult care. She continues to participate in research projects specific to sickle cell disease and investigations regarding students' disclosure of invisible disabilities to access disability support services in higher education. She has shared this information with patients, families, professionals, and community partners nationally and internationally. All right, and so with that, I will stop sharing my screen.
And then Dr. Lance, we have one question before we actually start. James asked, Dr. Lance, would you suggest neuropsych screening for all genotypes?
Sure. So all genotypes should be receiving developmental screening, again, from the general pediatrician. That's something that's true for all children, regardless of whether or not they have sickle cell disease. I think the sickle cell disease part is that screening, again, by the pediatrician, by the hematologist, by whatever provider is seeing the patient, should involve some targeted questions specific to concerns about the frontal lobe of the brain in particular. And so while that screening is more important in the genotypes of SS and S beta null thalassemia, all children should really be receiving the screening. In terms of the neuropsych evaluations, again, I think that could be more targeted towards children with SS and S beta null type thalassemia, but any child with sickle cell disease with learning concerns, academic concerns, developmental concerns should be evaluated. So I think it's less about the genotype and more about the child, more about how the child is doing and what the parents' concerns are. Great question.
Thank you. All right.
One more question in the chat. At what age is it necessary to start screening for these conditions? Is there a suggested timeline to monitor certain areas such as hearing, eyes, brain function, mental and physical health? What type of tests are conducted to diagnose these things? Thank you.
Yeah, so another great question. So actually there are guidelines for general pediatricians as well as family practice doctors to evaluate children at specific ages for all of those things. So, you know, when you take your child for the well child check, they're usually going to get some sort of vision exam and hearing testing just to make sure that that's good. So that screening happens pretty regularly at the well child checks and at certain ages. I don't know that off of the top of my head, but I do know that that's happening. In terms of the developmental side of things, children are actually supposed to receive developmental screenings at ages 9 months, 18 months, I think 30 months, and then again at ages 4 to 5. But really at every visit, every well child visit, the provider can check in with you about if you have any concerns about your child's developmental, cognitive, academic, or even mental health as well. So at any point in time, it's okay to bring that up with them. If you have concerns, they will likely refer you for a more complete evaluation. But the screening evaluations are really what's supposed to catch children at different points in life when they may present with different things.
Thank you. All right, so it looks like we're going to get started with our first speaker.
Hello. And thank you, Dr. Lance, for that wonderful introduction. Thank you. I am so excited to be here. My name is Aisha Gilliam, and I am one of the educational liaisons at St. Louis Children's Hospital and Washington University that supports our patients and families with sickle cell disease. So my presentation is geared towards bringing families and schools together. Some of the objectives that we're going to be looking at today, we're going to be identifying the impacts of sickle cell disease and helpful accommodations, also identifying educational plans for qualifying students, and outlining the responsibilities of responsibilities of the family, the student, and the school as well. So as your educational liaison, I am supporting our families and schools and the medical team for the patients that we service. This may look like helping communication between families and school personnel, which is very essential for building that positive academic outcome. Also, every child at St. Louis Children's have access to me, full-time education liaison, which is there to support them through their academic success and helping advocate any of those needs. I consult with the families, the child, and also try to gauge what those personal goals look like, as well as communicating with administration at school, the nurses, other teachers that may be coming in contact with the student, and helping to arrange any supports and services that you may need to help take away any of those barriers that you may encounter as well. So bringing families and schools together. So caregivers are concerned how their child will function in the classroom setting. They're wondering, will my child have the accommodations that they need? Do they understand the symptoms of sickle cell disease and how their child may be feeling? Also, how will classmates react to them, to their child? And then, of course, schools have questions where they're wondering, what kinds of accommodations do I need to do for your child? Also, where should they sit, or do they need special transportation? Can they participate in recess, or do they require any special plans such as a 504 and an IEP? We'll get to that. Also, is there tutoring or homebound that's needed? So some of the main impacts in my experience of working with our patients and families, I've noticed that education is impacted with school attendance, okay? Also, behavioral problems can exist for our patients as well in the academic setting, and just having overall academic difficulties with keeping up with things. What impacts does sickle cell disease have on education? That's what we're looking at here. So through working with our students and families, I have noticed obviously there's been an issue with school attendance, which I'm sure that you all are familiar with that. Missing those days of school and what that looks like. We'll dig into that a little bit more. Also, behavioral problems, start to also be an impact on education as well. We'll look into that and dive in. And just overall academic difficulties. We know that these are three of the main areas that your child or the child that you're caring for has experienced, as well as anyone who has had a child in their school buildings or institutions and things of that nature that have maybe encountered these same concerns that you see outlined here. So when we're looking at school attendance, some of the main concerns here, we talk about building those relationships with the staff and the peers. Of course, that's going to be very difficult to do when you're not, at school. That's more challenging, as well as decreased self-esteem. We see that also, and lack of motivation. So these are three of the main concerns, and I'm sure there may be others as well, but these are three of the main areas that have been mainly outlined when we see a lack in school attendance. Some helpful suggestions in this area would be definitely looking at other ways of bringing to the table access to education. So we talk about here, all students learn in various ways, but there's so many different ways to present the information. You can use online curriculum, definitely making sure tasks can be emailed, Zoom, which is the new way now that we're all familiar with, as well as a flipped classroom model, having videos, even Skyping, okay? So just getting more creative with how to help the students access this material if they're out from school, okay? Minimizing the workload. It doesn't mean that you're taking away from the curriculum, but it means you're looking at the essential pieces to what that is. So if the goal is for you to be able to know the quadratic equation, then maybe you don't need to do 5 of those problems. Maybe you can do 2, if you can show mastery in that level. But minimizing the workload, okay? Homebound instruction. Homebound instruction is a good tool to use in addition to also being able to attend school when you're feeling well. So homebound, what that allows you to have is a teacher that would either work with you remotely or actually come into the home or another community setting to work with you on the tasks that you've missed from a full school day, okay? So typically that may look different district by district. So you definitely want to talk with your school team about what the homebound instruction could look like for your child. Academic difficulties. We know those are going to be some areas that's going to exist. Difficulty meeting the curriculum requirements. playing catch up, which can also increase anxiety. Because if you are a student that maybe you've missed 3 days in a row, and we know that different subject areas build on one another. So if you've missed some days, then of course you're going to feel very overwhelmed and anxious trying to complete all these tasks. And let's not even throw in if you've missed the test, right, or quiz. That's another layer. So definitely playing catch up is one of the major concerns with many of our school age patients. Poor grades. You know, you've been out or you're not able to keep up with the curriculum requirements. You may struggle in that area of keeping your grades up as well. And we have to look at the medication impacts on academic performance. Some medications may make you more drowsy and you're lethargic, so you're not able to be as focused as you would like. And sometimes some medications you can't even take and go to school, okay? So that can also be an impact and something to speak to when you're working with your school team as well. And for the school team to think about when creating unique plans. Helpful suggestions. So let's look at, like I mentioned before, mastery versus completion, okay? So can you master doing so many math problems such as the quadratic equation? I keep going to math. I'm a past math teacher. So you think about mastery versus completion. Do you really need to do 10 of those problems or can you just do 5? Okay. So thinking about that's a helpful suggestion there. Extra books at home. Okay. Having the materials that you need available to you. Also deadline extensions. Yeah, a project may be due at a certain date, but can we extend those deadlines? Okay, can we also freeze that grade and look at maybe a suggested project or something like that to also help to meet those academic requirements as well. So looking at those deadline extensions, reviewing the essential parts of the material. Got a little typo there. Reviewing those essential parts, looking at the main pieces of what needs to be covered, okay, in that curriculum. Access to other possible learning, assessing other possible learning disorders. So let's just say there's something more going on there. Yes, the child that's in your classroom may have a diagnosis of sickle cell disease, but it doesn't mean that that's all. There could be some other things going on there where you need to really dig in and assess to see if there's any learning disorders that are existing, okay? I always put this out there because we know that there can be concerns with vision and hearing. So making sure that you're up to date on vision and hearing screenings for, before going into the academic setting. Sometimes if there's some concerns with vision, that's going to reflect in your academic performance as well if there's concerns with hearing, okay? So making sure those screenings are up to date and done regularly is very important because those can impact your academic performance. Behavioral concerns. So we don't think about that a lot of times. And it's definitely one to also begin to see and really dig in when you have a patient, a student that you are encountering, okay? And some of the concerns here, when there's extended absences with minimal peer interactions, that can create a discomfort socially. So you think about, you've been gone for some time, your friends are wondering, where have you been, what's going on? Or there's a new activity they really want you to participate in. And, the social demands of that, can just be very weighing. And, you begin to want to avoid contact with your peers and you're tired of the questions and you just feel like I'm always trying to refit in again, always, right? Reintegrating. And so that can create some behavioral problems as well. And social phobia and or separation anxiety. Because if you haven't been in school often or the child hasn't been in school often, there could begin to create some of those phobias of coming back into this setting because you've spent so much time away, you're always feeling like you're being reintegrated again. And so being able to know that that's a concern and how to address that is going to be very important when developing the plan and talking with your school team. Vulnerability to teasing / bullying definitely can play a part in behavioral concerns. You may begin to want to lash out. Someone may want, feel a certain way. And being able to be mindful of these things is very important because they do exist. And it's important to have your hands up to be aware of this when you have a student that is in your classroom or in your school building. And also, just as a caregiver, just knowing and being mindful of these things is very important as well, because this can also increase the likelihood of a child not wanting to attend school. Okay. Vulnerability to isolation, kind of mentioned that a little bit before, not really wanting to explain things and having to give your story over and over, or, just feeling very isolated as if you're the only one that's dealing with this and feeling that way. And needing support going through that, that's a concern. You want to make sure that we are paying attention to those things. Adjusting to the social demands of school, that can also be very difficult. You think about if you want to take part in an activity, but maybe you're not feeling well enough to do that. School dances, field trips, you're thinking about what I need to have together to be able to go to these activities. What are some things that need to be looked at for me not to have barriers in attending these activities. So those are some concerns that can definitely create some behavioral problems, but there are suggestions. So definitely seeking therapeutic supports, getting that mental health counseling. If you see that there is some concerns in any of these areas with one of your peers or with one of your students or your child or the child that you're caring for, definitely you want to, I always encourage counseling when needed. Social skills and peer interactions, creating opportunities for that. It's very important to be mindful of connecting with social skills and helping those to connect with other peers as well that may be dealing with this area of concern. Support after extended absences. So being able to meet with the team to figure out, good supports if the child is missing days of school or just needing that good peer interaction, like pairing them up with a buddy or something of that nature, but getting creative and thinking about what that looks like after there's been an extended absence in reintegrating the student back into the school atmosphere. Group or partner projects is always also a good way to help to build relationships and just to kind of ease that anxiety. And normal treatment. Of course, we know that you may have a child with a sickle cell diagnosis, but it doesn't mean that they should be treated any different. Treat as normal as possible outside of making sure, of course, their accommodations and things of that nature when it comes to the medical stance is met. But as far as, treating them like a normal kid, not always, just pointing out or highlighting that they do have this diagnosis. So we're going to talk about some educational plans. So we talked about some of those areas that have been impacted, but how do we really dig in to get a good educational plan? So children can qualify for an educational plan. So one we're going to talk about here is called the Section 504 of the Rehabilitation Act from 1973. So the 504 requires that a child with special healthcare needs, such as any limits to one or more life functions, be provided with ways to participate in general education programs. So students with sickle cell disease have been identified as eligible via Section 504. A 504 plan is a good tool that helps the students receive needed instruction both inside the classroom and during times of absences due to complications. So it's a plan where that can make a significant difference in the student's learning experience. Many times in the school, so this is more of like your health plan, right? And it doesn't necessarily mean that you need any specialized instruction, but you may need some extra supports, some of those accommodations, which we'll talk about in a bit. But it outlines a plan. It says, you know what, my child has this diagnosis and they're going to need some support at school, and I need the team to know what my child needs. So this kind of outlines some of those basic things that your child would need in that environment, as well as making sure that there's a plan when they miss days of school. So if they miss a day of school, what does that look like? This plan would help with that, okay? So this is your health plan for making sure your child would have some of those minimal accommodations if needed. Many times the school nurse or the counselors are responsible for creating these plans in school, but it's best to always ask. My go-to is always to ask the school counselor or an administrator about the plan. The school nurse is a good contact, but it's also important to reach out to the counselor or the admin as well to make sure there's other, key team players that are part of that admin team to work out the plan as well. Children can also qualify for another type of educational plan, which is called an IEP, Individual Education Plan. Some students with sickle cell disease may qualify or already be classified under the Individuals with Disabilities Education Act. IDEA is having a disability that requires special education and related services. So for those students, the IEP will include accommodations, as the 504 did as well, but also some modifications that are related to the classification of the disability, all right? In addition to those accommodations or modifications, there may be additional suggestions made by the student's physician as well that can go into this plan. So when we're talking about the IEP, we're talking about more of specialized instruction that would may require a modified different type of class, or that also may require any type of special related services. Okay, so this is an addition. This may be another health impairment diagnosis or any other type of learning disability as well. So when there is a disability that will adversely impact the child, okay, and their education, then we start to look into the IEP, okay? We start to look into, okay, they may need this specialized learning plan, okay, to help them at school outside of just your typical, your accommodations under the health plan. So you may need something that's more specialized. So this is where more that testing comes into play, okay? And your child may be evaluated to see if they qualify, okay? So then we look at some helpful accommodations. These can be outlined in your IEP or your 504 plan. So these are just a few that I have used and worked with different schools on. And I'm sure many of you may have seen this as well. So we talk about here being careful with the temperature outside. We always kind of steer around, below 40 or over 85 to be mindful of avoiding those temperatures, but every child is different. So definitely this is something you want to work out with your school team. Going through is, recess, PE, what does that look like? Needing those breaks, being able to wear a jacket, depending on the temperature, a coat, carrying your water bottle, fluids. We know how important that is. If you need a snack, especially depending on what type of medications you're taking, you may need a snack at a certain point throughout the day. And if you have meds in the nurse's office, also that's something to consider, needing a snack. Frequent restroom breaks are needed. Access to the nurse or office staff for medical needs. Transportation, this is a big one. So a lot of times I am supporting a lot of our patients to making sure they have a bus stop that's close to home or right at the curb, okay? This way you're not standing outside in the cold waiting on a bus, and you're able to get that door-to-door, curb-to-curb transportation set up if your bus stop is so far away from your house, or if you're a walker for school and maybe that's not something that's ideal, okay? So talking about those transportation accommodations is key as well. We kind of went and talked about a little bit of the home instruction, reducing the workload, okay? And a few others. But this is just a snapshot as to a few accommodations and modifications that I have supported our families with, but I'm sure you can think outside the box on many others as well, because there's many others than just this list, believe me. So who needs to do what? This is key, okay? The family. So everybody has a part. That's the big thing. Everybody has a part. And it's important that you know your part, all right? This is a team effort. It doesn't fall on one person, okay? To get a good solid plan in being successful in the academic setting, everybody has a part. So for family and the student, who does what? Family, we want to make sure you're notifying the school of the student's health management needs and their diagnosis when appropriate. So communicate as early as possible. So we think about the beginning of the school year. I say start before the first day of school, of course, making sure you're getting that information to the principal, okay, your nurse, your counselor. If there's no counselor, your social worker, making sure the school is aware, and definitely the teacher. You never want to leave them out. I always encourage a meeting before the start of school, especially if the child is new to the school building. Provide a written description of the child's health needs at school. So this may be any authorizations for medications that they can take, emergency treatments, also anything that needs to be signed and turned in by the healthcare provider. Participate in the development of the plan to be implemented for the student. We want to make sure that you want to meet, as I said before, with the team to make sure you have the best plan outlined for the student, okay, and their needs in that setting. So I always encourage that, at the meeting, in the beginning, that a meeting takes place, all right? This way, any exchange of information between the school and the student and healthcare providers, all that's very clear, all right? Provide the school with the needed medication. So you have to make sure the medications are at school, okay? Nobody's going to make sure that they're there. You have to make sure they're there, they're labeled, everything that they need, and the information on how to administer those is labeled on the medication as well. If they run out, you have to make sure more is there. So if it's ibuprofen, you have to make sure that ibuprofen is at school. Also provide the best way to contact you. That has been, if there's an emergency, give your number, give a backup number, make sure that information is somewhere at school if there's an emergency, okay? And that can be a part of also that plan, right, that's outlined for school. Educate the student as well to develop age-appropriate self-care skills. So if you have, let's just say, a fifth grader, okay? And if it's cold out, hey, honey, make sure you got your jacket on, make sure you got your hat on, just, developing those self-care skills and promoting good health, okay, and personal care, nutrition, and things of that nature, okay? Student, you got something too. Communicate. So if you're, this of course is age appropriate. If you're old enough and comfortable enough, I always encourage the students to communicate with an adult about concerns and needs when managing your symptoms or the school environment. So if you're struggling with stairs, speaking to an adult at school about that. Also, if you are needing to take your meds or go to the nurse office, being able to communicate those things. So you have a responsibility, if age appropriate, of course, to make sure you're communicating your needs or any symptoms that you may be feeling if you're not feeling well. Also participate in your care and management of your health, as appropriate, of course, depending on your developmental level. I always encourage you to also participate in those meetings as well. So we're speaking to the family that's being at those meetings overall, the caregiver, the parent, and also the student, if appropriate, to participate in those meetings, as well as the team. So school has a responsibility. Identifying the students with sickle cell disease and reviewing their health records as submitted by the families and healthcare providers. It is definitely the school's responsibility to know what children are in their possession, especially the children that may have special healthcare needs, okay? and that is going to be attending school. Also arranging those meetings to discuss the accommodations and modifications and services that are needed. If there's a 504 plan that's needed, if there's an IEP, if appropriate. So making sure those plans are developed. Providing non-discriminatory opportunities to students with disabilities, be knowledgeable about and ensure compliance with the applicable federal law. So make sure that we're following the plans that we need to, and that we are giving each student, let's just say, a fair shot at their education experience, okay? So making sure that happens. Explain the roles and obligations of specific staff members. So if someone is supposed to be monitoring a specific outcome or goal, then that's outlined. It's very clear to the parent who's going to be monitoring that. If the child is supposed to check in with a certain teacher in the morning or check out, you know, all of those kind of roles definitely need to be set up and explained as well. So developing just a good communication system. So you think about attendance. Who should the family contact? Sometimes it's the office, sometimes it may be the teacher. So making sure those lines of communications are clear. And of course, communicate with the family regularly. So if you know the student has missed several days, who knows what could be happening? So feel free to reach out, right? It shows that you care, but also it's just another level of making sure that we're doing our part, that you're doing your part. Okay, reaching out regularly if you have a question about something or if there's a need. Also, being prepared to handle any health needs and emergencies is very important on the school's part, and ensure that all staff who interact with the student on a regular basis receive the appropriate guidance and training on routines, precautions, and emergency actions. Okay, ensuring that the case management is provided as needed. So if you do have a student that has an IEP, making sure that the case manager is contacted, and also that it's very clear as to who that person is and who will be following the student. Ensure proper record keeping. This is always important, especially if there's an incident or something. It's important to keep that paper trail, making sure to measure the appropriate, both protect the confidentiality and any sharing of information. So I'm going to start that bullet over so we can cut that out. So ensuring proper recording. Sorry, let me start over again. Ensure proper record keeping. So this means including appropriate measures to both protect confidentiality and to share information. That's going to be very key because, of course, we don't want any violations to HIPAA. Okay. Promote and supportive learning environment. So the views the student with sickle cell disease the same as any other student, except when responding to health needs. It's going to be key. All right. So bridging that gap. So some good takeaways here. Keeping the line of communication open with caregivers and school staff supporting the student. Collaboration between special education, general education for related services and other supports. And I throw that in and I say that because even if the child doesn't have need special education or a specific case manager under an IEP, there still could be really good tools and techniques or strategies that can
Okay. Everyone, patience for the pause. Golda. Golda, are you still there? All right, everyone. The patience for the technical. Okay. So I'm going to text Golda I'm sure she's aware. Okay. I'm sure she's aware that it actually dropped off. So give us a moment. I think in the meanwhile, why don't we, Dr. Lance, why don't we answer a few questions, and we're going to get the final portion of the first talk. So I actually have, so everyone, thank you. And we're going to get back to finishing up that first talk. So let's see. In the Q&A, we had from Kia, my son had silent infarct at age 9. He's now 15 and has never had any more. Will he have more of these in the future?
Yes. So because he has a history of having them before, that does put your son at increased risk of having more in the future. However, it's very good that he hasn't had any more since he was 9. In addition, I think what's most important would be to monitor his cognitive status, his academic skills, as well as to adhere to whatever treatments your hematology provider has recommended for your son's sickle cell disease. That's really, those are the things that you can do to help him now and to give him the best chance of not having more in the future.
Thank you. Kiran asked, besides disability, what are the long-term complications of a severe stroke and the implications of less severe strokes?
So for this question, it depends. So it depends on the location of the stroke and how severe the stroke is in terms of what it affects. So again, if it affects the frontal lobe of the brain, that can affect your language, that can affect and that can affect other things. If it involves more the central parts of the brain, it can affect your motor skills, it can affect your sensation. And then depending on what age you are, your brain is actually able to recover from stroke. So in younger children, they have what's called brain plasticity, which basically means that they can recover from a lot of injuries a lot better than adults can. And so that can mean that a severe stroke may affect a younger child less than an older child or an adult. And then in terms of the less severe strokes, I assume you're talking about silent cerebral infarcts. And those can also, again, because they primarily occur in the frontal lobe, they can really affect your attention, your working memory, your processing speed, really your executive function. And so those are, that would be the answer that I would give for those.
Okay, thank you. It looks like Golda is ready to start the pre-record to complete the last portion. Golda? And there's no video, sorry, audio.
Share your audio, monetize it. I mean, optimize it, Golda.
In the hospital setting, and some time in the home setting, and then some time also in the school. But for the most part, it's also some community resources that we need to, let me start that over, and how we can support them. So yes, we know the medical piece that speaks for itself, that's taken care of. And then we have the educational piece. But what about when they're not in any of those environments and there's other supports that they may need some help with? So we talk about also other activities to get them involved in and other resources that can also help to elevate, all right? So it's okay to also be connected to some community resources. That's a great way to also look at supporting the whole child. And then we talk about building relationships. That's always key. Building relationships is always key. Okay? references there. We'll skip past that. And then we talk about post-test. Here we go. Okay, I think this is the teacher in me getting excited. All right, let's see how you did. So post-test question 1 says, having sickle cell disease qualifies you for an IEP. True or false on that one? Which is an IEP is an individualized education plan. So having sickle cell disease qualifies you for an IEP. Think about it. All right, question 2. Who should take part in the school planning meeting to share information about the medical needs? Who should take part in the school planning meeting to share information about the medical needs? Should it be the student, the caregivers, the student, if appropriate, and caregivers? Only staff at the school is allowed to attend. Think about what I said. Hopefully you were listening. And now for the big finale. Some answers and rationale. So question 1 would be false. To qualify for special education services, a child must have one of the 13 disabilities as defined by IDEA, and the impact of the disability must create a need for service. Okay. If you chose C, you were correct. So the student, if appropriate, and the caregivers, having both attend will give the school key information when developing the best educational plan. Keep in mind also, the school may not be familiar with your type of sickle cell disease. Each student has unique needs. And that's why it's important for everybody to come to the table. I thank you for your time and attention. I appreciate you. I hope that you learned something new during this presentation. I'm very humbled to be able to be here to do this. And if you need to have further contact with me, I think that Dr. Lance will have that information. I am here for questions and any further comments. I appreciate you. Have a great day.
Okay, thank you. We did have a question. So now is the time to put your questions, either raise your hand, put the questions in the Q&A and or the chat. And there is a question. How would you navigate a conversation with the school team concerning a toddler's need for constant hydration and specialized nutrition?
So if I could, hi, I'm Latasha, I'm your next presenter. That question may be answered in my presentation. So if we could put a pin there and come back to it possibly, if you feel that I did not answer it.
Perfect. And I believe that is the question. Those are the questions at the moment. We do have a hand raised. Let's go to our allow the person to talk. Okay, so you're able to speak now to ask your question. This is for the redeemed child of God. Oh, I'm sorry. You'll have to also unmute yourself. There you are.
Oh, there we go. Oh, that was frozen. Hello. I had
Hi.
a question. I missed the first part, so I'm not sure if this is the correct portion of the program, but my mom suffered 2 aneurysms, and I wanted to know if I was at any risk of suffering from brain aneurysm.
Does your mother and do you have sickle cell disease?
Yes, my mom has trait. I have the disease.
Oh, okay. So I think it's a good question. I do think people with certain types of sickle cell disease can have an increased risk of vascular changes like aneurysms or other things. And so that is something that you can check for through an MRA. So an MRI of the brain is more looking at anatomical things. An MRA is an angiogram. So that's looking more at the blood vessels of the brain. I don't think that your mom having an aneurysm and having trait puts you at increased risk. I think people with sickle cell disease can have an increased risk, again, for vascular changes. But if your mom has an aneurysm for some other genetic reason, then that may actually have something to do in terms of your risk as well. So.
Thank you.
Another question, what is the school's responsibility to get the parent to the IEP or accommodation meetings? Is it important for patients to actively participate in the meetings?
Why don't I just answer that? So the school's responsibility is to invite the parent to the meeting. And that's assuming that the parent has already disclosed and that there's already been some testing and that the child has already qualified for an IEP or has already had an initial 504 plan developed. So after the initial stuff, which again, it's the parent that gets the ball rolling. You know, schools are getting thousands of new kids each year, and there's no way that they can know that a child has sickle cell disease unless the family shares that information with them. So once the family shares the information, then it becomes the school's responsibility to provide services, whether that's through a medical health plan, an IEP, or a 504 plan. And so I'll talk a little bit more about the differences between those. But yeah, the parent and the school has responsibility, as Ms. Gilliam's presentation talked about.
Yeah, and Ms. Gilliam just sent in one last slide about what does the educational liaison help do. So I think that'll kind of go well with what Dr. Hamilton was just discussing. Share it real quick.
Thank you. We do have, I'm going to, we have Jamie who wants to ask a question. Please unmute yourself.
You actually asked my question earlier.
Okay, thank you. Let's see, are there other, we're just checking real quick before we go on to the next presentation. Okay, so, and thank you, Stephanie. She said all of the info is all well done. So thank you. All right, I think we're ready for the next presentation.
Awesome.
So I have to apologize. My neighbor just now started doing something outside of my window. So if there are any problems hearing me, if you'll indicate that, I'll try to speak a little louder so that you hear me instead of the lawnmower or whatever's going on outside my window. But I am Latasha Hamilton, and I am an academic coordinator. That's my official title at St. Jude Children's Research Hospital in Memphis, Tennessee. And I have been there about 12 years now. And one of the things that I think is most important to tell you guys is that I continue to learn from our parents and our families and our kids with sickle cell disease. And just the fact that you guys are engaging in this series today on Saturday, it really shows your commitment to your child and what great parents you are, and educators if there are any who are concerned about our kiddos with sickle cell disease and who are concerned about helping them to be successful at school. So I thank you for that. I do want to tell you that I have no conflicts to disclose, and that's just a picture of our campus here in Memphis, Tennessee. And my objectives are here. I'm going to explain the school services that I provide. So that's what I do. I'm also going to explore the impact of sickle cell disease complications on academic performance, which you've heard from Dr. Lance and from the previous presentation, but that's what sickle cell does. And then the last one is I'm going to identify the benefits of educational plans and identify appropriate accommodations to include in those plans. And that is what you, the parents and the educators, can do. So again, I think the message is being repeated that there's a part for us all to play in this. So here in Memphis, you see that little blue star there. We are kind of in the southwest corner of the state. And so our catchment area, which is about a 200-mile radius, includes families from Mississippi and Arkansas. So I am working with families from Mississippi, Tennessee, and Arkansas. And as you can imagine, there is a lot to contend with. Of course, there's federal legislation that is appropriate for all three states, but then the state laws, they get a little bit different, though they're similar, they're very similar. But then we get to the local school districts within each state, and there can be a lot of variability from district to district and of course across those state lines. But I will tell you that in my almost 12 years of doing this work, educators are typically very happy to see me, and they're happy to get this information because they want to do well by the students who are in their classes. Excuse me. So at St. Jude, we treat a little over 900 patients with sickle cell disease. And this is a breakdown of our population. We have our infantile clinic, which is birth to 5 years of age. Our school age clinic is 6 to 11, and our teen clinic is 12 to about 18. For most kids, 18, depending on how stable they are and if something is going on. But we transition about 50 18-year-olds each year to adult care, but at the same time, we are identifying about the same number of newborns with sickle cell disease each year. We start to see them and we start to provide school services at age 2. And the academic coordinators are part of the treatment plan. So we're going into the clinic room and visiting families as they are coming to see us for their routine clinic care. So our program is called the STAR program, and STAR is an acronym for Success Through Academic Resources and Research. It was originally an in-house tutoring service that was offered to our families in the afternoons, but because of logistics and time constraints and transportation issues, they later adapted the program so that instead of trying to get families to come to a tutoring program, the academic coordinators started to go out into the community, to go out to the schools and work with them to provide the accommodations that kiddos would need on a daily basis in the school setting. I will tell you that all of our academic coordinators are licensed educators. We came from the school system. I was a school counselor before I transitioned to St. Jude, but we also have someone who was a special education teacher. We have another person who was a high school biology teacher. So having been on that side of the aisle really helps our families to advocate for their children to get what they need when they are going to the school. And our goal is to really increase advocacy with our families. We want to teach them how to advocate for themselves, but we also want to help to provide more education about sickle cell disease in the community. And so you see there that those are the four priorities of our STAR services. So we're educating other educators. We participate in presentations for the school psychologists, the school nurses, any group that's working with our kiddos consistently, they could arrange to have a presentation provided by our STAR services. And again, that outreach, we are going out into the schools. We're also working with other community partners. For example, because I work with the teens specifically, I've also worked with the vocational rehabilitation counselors. Vocational rehab is a federal program that assists with post-secondary planning. And because our kids with sickle cell disease may qualify for those services, I've tried to really work with helping those voc rehab counselors to understand exactly what sickle cell disease is and how it impacts education and thus impacts quality of life after high school. And we're also participating in advocacy and in research. And I don't think I'll have time to tell you about any of our research projects today, but you can definitely go to our website, stjude.org, and see some of the projects that are going on there at the hospital. So I think it's important to tell you about the two pieces of legislation that might be the most important in the K-12 setting. Ignore that. So again, you've heard these in the previous presentation. The 504 plan, which falls under the Rehabilitation Act of 1973. I don't know why I have 8 there. And then the Individuals with Disabilities Education Act, or IDEA. I put these on the same slide because I think it's important to make some distinctions between the two that people don't always understand. First of all, the 504 plan can be obtained differently from the IEP. So for a 504 plan, if you have a condition or a disease that impacts daily life activities is what it takes to qualify. It's as simple as that. You need a medical provider to document it, but it simply has to impact daily life activities to qualify for a 504 plan. An IEP, on the other hand, the qualification is different in that it requires testing. It requires achievement and IQ tests. And typically, schools will provide an achievement test each year. In Tennessee, it's called the TCAP that our kids take every spring. But additionally, there has to be an IQ test. So they're just trying to determine your child's ability to learn and then what the skills that they are gaining each year with that achievement test. So any school that gets federal funds has to provide 504 plans to the kids and IEPs. 504 plan falls under, again, the Rehabilitation Act of 73. And this is a civil rights law, which is different from the IEP. Again, it doesn't require medical documentation, and students do not have to have both of these plans. If a kid has an IEP, which has a little bit more teeth, it provides more services. The 504 plan is inherent, it's built into the IEP. So a child who has civil rights covered by the 504 plan will also have his or her civil rights covered with an IEP. I will tell you too that 504 plans make accommodations as opposed to IEPs, which provide modifications. For example, if your child is a 5th grade student, with accommodations, he might still be expected to do 5th grade math, but he's allowed to use a calculator. He's allowed to have extra time to do those assignments. If he has an IEP, though he's a 5th grader, he may be doing 2nd grade level math. So that's a modification versus an accommodation. IEPs are, again, the law is a little bit more structured around IEPs. the request for an IEP, the timeline. It's all very specific. It's all very outlined in the law. So the testing is good for 3 years. Once that psychological testing is done, it has to be recertified every 3 years, though each one of these plans should be modified each year. So you certify every 3 years, but it's a good idea to develop, review, and revise the plan annually. Because think about it, even if nothing changes for your child, their teachers typically change. So you want to go and have a meeting with them so that they know you, first of all, and that they know your child, and you're giving them the most up-to-date information. So these are the types of plans that we see at school, or that we see, because sometimes the IFSP, which is the Individualized Family Service Plan, we see those before a child actually gets picked up by the school district. So because the IDEA covers students from ages 3 to 21, school is responsible for services even before a child may enroll in pre-K or kindergarten. So at 3, if a child is deemed, and this is done through the Well Child services that Dr. Lance mentioned, if a child qualifies for services for an IEP or what looks like IEP services through an IFSP, those services can start as early as 3. And sometimes it looks like someone coming into the home to provide physical therapy or speech and language therapy to your child. An individualized health plan is typically something that's done by the school district. And so if your child transfers to another school district, it may not hold up. So the health plan is typically something that's created by the school nurse, and it really only addresses medical needs, as opposed to the 504 plan and the IEP, which can include medical needs and can include those academic needs for your child. Also, when your child transfers to another school anywhere in the United States, again, any school that gets federal funding, that 504 plan and that IEP should follow him. It should be transferred with the rest of his records. So the steps of scheduling a school meeting, I want to tell you, but probably again, the most important thing I want to tell you is that parents have power. Parents have power. So as a parent, if you call and say that you want a 504 plan meeting or you want to discuss that, the school has to respond. If you call and say that you want your child to be tested for special education services, the school has to respond. So parents have power, but working together as a team is what's most powerful. And that's important. You know, even in the work that I do, I can come in and I can help to bridge the gap between the school and the medical team. But then I go back to the hospital, you know, the parents and families and the teachers, you guys are the ones who are still there at the school every day. And so working together is super important. So here are the steps for scheduling the school meeting. Call, email, or visit the school. I really encourage parents to email. You know, I like to put things in writing so that it helps us all to have that accountability. The email has the date on there, so you know when exactly you asked for the meeting. Ask to speak to the 504 plan coordinator, which may be the school counselor, or it may be a grade level administrator. Ask to speak to that person, request to start the process, and they'll get the ball rolling. Typically, they'll ask for medical certification, which they may give the parent a form to bring to the hospital, or they may ask you to sign a consent form so that they contact the hospital directly. But typically, we'll provide that certification, and then the meeting is scheduled. We all come to the table and we decide on, so my last one says show up to the meeting. Listen, I say that because there've been a number of times that I've shown up to the school for meetings and parents weren't there. And again, because parents have the power, my being there is not as important as a parent being there. So show up to the meetings, bring your concerns, bring your documentation, bring your questions, and we'll put all that on the table so that as a team, we address those things and we create the best plan for your child. Again, the goal is to help your child to be, or help this child to be successful. So keep records. When you talk to people, write down their names, write down the date, write down whether you talk to them in person or on the phone, write down if you talk to them via email. Keep a folder of all of your records, of all of the forms that they give to you, all of your copies. This is all going to be important for just helping you to advocate better for your child. Who should attend the meeting? Basically, anyone who has any significant contact with the child throughout the day, parents, the student themselves. So there's a certain age. In Tennessee, it's age 16 that students can actively participate in their IEPs. But I really like the idea of having a meeting and maybe in the last 5 or 10 minutes of the meeting, having the child to come in. I think that that helps them to understand, again, that they have rights, and it also helps them to understand the advocacy that's going on their behalf, and it models for them how to become advocates for themselves. So these are the people, again, who are involved. Others as needed, maybe there's a gym teacher, or if your child is running track, maybe the coach should be involved. If your child rides a bus, here in Tennessee, we have some rural areas where a child may be on the bus for 45 minutes. So it may be important for that bus driver to understand what sickle cell disease does to a child who may be on a hot bus or a cold bus, depending on the season. These are some of the concerns that you've heard about: attention problems, those executive functioning kinds of skills, planning, organization, transitioning from one activity to another, receptive and expressive language. Those are things that we are concerned about and that we may address in the 504 plan or IEP meeting, especially if we have test results. So again, psych testing is very beneficial in helping us to advocate for kids at school. It helps us to identify specifically what the problem is so that we can identify accommodations that best address that problem. For example, a child with a slower processing speed, which means that they just take a little bit longer to understand what's being asked for them, to figure out how to respond to that and to give an answer. Well, maybe they don't need to do time to test because it takes them a bit longer. So psychological testing is super helpful and super important. I wanted to share this research with you. It was conducted in 2010 by Simon Martin Dyson, and it was conducted in England. But I think that it was there's some research, some suggestions from our clinic and from the academic coordinators that this was similar to what we were seeing anecdotally here in the Mid-South. But Mr. Dyson looked at, I think, 569 questionnaires, and he also did some interviews. And he was trying to understand students' reluctance to disclose that they had sickle cell disease. And interestingly, this is some information that he found out in that process, that students were sometimes prevented from taking a drink of water in class. And we do say water. We're not advocating for them to have Cokes. The love of my life is a Coke, but we're not advocating for those kinds of things. It's only water, possibly Gatorade. Students were prevented from going to the bathroom. They were made to do exercises that were unsuitable, and they were called lazy when they were feeling tired when they did do these things. Again, I say that many times in the schools, the teachers just don't understand sickle cell disease. They don't understand how your child looks so well and looks so healthy, and then the next day they can be in excruciating pain, or then they can miss school for the next 10 days, right? So It's about educating teachers about sickle cell disease and how that impacts your child. And again, putting that 504 plan in place so that they have appropriate accommodations. This was also interesting, so I wanted to share with you. The triggers for a pain crisis that started at school was, again, students being made to do exercises that are inappropriate, prolonged exposure to extreme hot or cold temperatures. You know, we know that students are going to have to go outside to get to inside sometimes, right? We know that there are certain situations where they're not always within control of the school officials, but if school officials are aware that that prolonged exposure can trigger pain crisis, they typically will make arrangements, even if it means that the child goes to sit in the counselor's office, or, and I'm just thinking about a fire drill, for example. If a school does a fire drill here in Tennessee in August, where our temperatures are close to 100 degrees, you know, it's not appropriate for our kiddos. So they may be allowed to stay inside in the front office with the administration staff as they're trying to get it all worked out. Also, the school furniture, having appropriate furniture to make students feel a bit more comfortable, that can trigger pain crisis for kids. There's so much I could tell you. I'm trying to stay on task. So this is, we share with all of our families what we call our school letter. And this is a letter that identifies general accommodations for our kids. And some of these, again, you saw in a previous presentation, and you also saw more specific accommodations in the previous presentation. And I think it's important for you to remember, these are general. These are general to all kids with sickle cell disease, but what your child specifically needs, we can address that in the meeting. We can address that for each individual. That's why it's called an individualized education plan. That's why the 504 plan addresses individual needs also. So we can look at the physical accommodations, again, whether it's controlling the temperature or making sure that there's appropriate furniture. Maybe it's access to an elevator if your child has pain in their legs. But we're also looking at appropriate academic accommodations, such as extra time to make up assignments when they return from absences. So again, when the team comes together and when there's appropriate communication, we can find the appropriate accommodations for the child. It's not always easy though. So I wanted to tell you about a specific case where it was not easy. So I used Trey as an example for a kiddo who moved to Memphis from Atlanta. He was 13 at the time, and he'd been diagnosed with sickle beta 0 thal. And so he had a history of frequent pain and headaches. And he had also had a decompression for Chiari malformation. This child had not attended school regularly in his past. I think he had, for most of his career, his school career, he had done homebound services. So think at 13 years old, he was going into 7th grade, if I'm not mistaken. So starting middle school, which is hard enough, right? Starting middle school though, without having really attended school regularly. And so then the surgery also had been pretty recent before he came to Memphis. He also had a history of leg numbness and hypertension. He later had some chronic pain bilaterally in both legs. So because the schools here did not have a history with this child, they had lots of concerns about his coming to school, and they actually pushed for him to continue to do homebound services. Now, homebound services is beneficial, but think about homebound services may be 3 hours a week with the teacher as opposed to 7 hours per day with the teacher. So our number one goal is always to have have students, to participate in the school setting. We do use homebound when necessary, when absolutely necessary. But we want kids to go to school. We want them to have more exposure to those skills and what's going on at the school, and to have that social exposure. That's important too. So again, the people at school, at this particular ABC middle school, they were resistant to Trey coming to school. And we did an initial 504 plan at one school, and they decided to transfer him to DEF middle school because they did not have an elevator at that school to accommodate his leg numbness and his pain. He eventually needed a walker. I think he used a walker and a wheelchair sometimes. But again, now that he's at DEF school, they're also pushing for homebound services because they were concerned about the liability to the school if he fell down or if he had an accident with another student. So I understand their concerns, and there's a way for us to address those concerns. But the appropriate response is not that we just send them over to homebound services because of your fears and because of your setting at the school. So the accommodations that would be appropriate for him would be to have extra time between classes. I think we settled on his even leaving 5 minutes or so before the other students so that he wasn't in the middle of a busy hallway trying to make his way to his next class. He also was provided an elevator key at that second school. He was assigned peer helpers for each class. So if he had any problems getting to the elevator, or if he had any problems with anything, basically his peers that were assigned to him could help him, whether it was to communicate for him, to communicate to the teacher, or whether it was to physically help him by carrying his books or going to get him an updated elevator pass key or whatever the case. He also qualified for special transportation. So he was able to ride the bus that accommodated his wheelchair or his walker. And also the special transportation allowed pickup at his front door instead of him having to go to the bus stop where the other kids gather, which I don't know how they assign the bus stops, but I've seen the distance to the bus stop be ridiculous for some kids. But we alleviated that problem by having the special transportation that picked him up and dropped him off at his front door. So these are all of the steps, though. These are all of the people, all of the agencies that I had to contact to get this child what he needed, you know? So the school district, we went all the way up to the superintendent. And when he didn't respond in what I thought was appropriate, we went to the State Department of Education. We talked to Memphis area legal services to help mom prepare for, you know, whatever the next steps may have been. And then we also contacted our regional Office of Civil Rights, which is in Atlanta for the state of Tennessee. We were prepared to go to the mats. And I guess it kind of sounds like we were already on the mats, but we knew that this child should be in school. We knew that this child needed accommodations to be successful at school. And eventually that did happen. He was able to attend school more regularly than he ever had. He was able to graduate. And now when I talked to him, he had a plan to study culinary arts, which I should have stayed in touch with him for that, if nothing else, right? But I did reach out to the family and I wanted to get an update on him, but I didn't hear back from them. So I want to show this video to you. And this is another child who transitioned from St. Jude maybe about 3 years ago now.
football teams, like #1 in the nation. So the band has to be full of energy and precise. I think it's kind of like therapy for me. It makes me feel like I'm normal. Like I can be normal. Music is life to me. Music is life. My name is Shania. I am 16 years old. I live in Basin, Mississippi, and I have sickle cell disease.
Even if they don't have a chronic disease, it's hard to be a teenager. They really have to be on top of taking care of their sickle cell disease, in addition to being exposed to the regular world and daily activities of going to school, participating in a sport.
The first time I actually found out she had a disease was when we were at a contest, and I saw her get kind of weak, and we were marching off the field, and I saw her pass out.
She's always just like pushed herself, and she's just works so hard.
Most of our teens, they don't want to be different. They don't want to have to stop and take breaks because it makes them look different or feel different. It is a chronic disease, and it is very vital to their care that they have a place that they can go that understands their disease. St. Jude is one of those places.
St. Jude Children's Research Hospital is primarily known as a place that treats children with cancer, but really from our start, we have had a program to treat children with sickle cell disease. It was a devastating disease at that time, but we've made great strides in improving the outlook for children with sickle cell disease.
A sickle cell isn't round like a healthy red blood cell. It's more banana-shaped, which makes it harder for it to carry oxygen and can cause pain and damage throughout the body. Since sickle cell disease is an inherited blood disorder, it's something our patients are born with, and they have to deal with it every single day.
I came to St. Jude when I was around 5 years old. Growing up with sickle cell, it was really different for me. I couldn't do what other kids did, like go outside. It was a struggle, but I came to see that if I didn't have sickle cell, I probably wouldn't be like the person I am. I don't want sickle cell to define who I am. I don't want that to be a factor like, oh, she has sickle cell, or she can't do that. Just because I have sickle cell, it doesn't mean I can't do anything.
Sickle cell disease affects about 100,000 Americans, and 1 out of 400 African American babies have sickle cell disease. It's a lot of kids.
So we've had great success in managing children with sickle cell disease. Greater than 95% will be able to make it through childhood. Our efforts to date, though, have really been in managing their symptoms. Today, in the United States, when children transition into adult care, there is a rapid increase in the number of deaths that occur in this population of patients. This is unacceptable. We need to better educate our patients so that they can play a more proactive role in managing their care as they transition into the adult care environment. Simultaneously, we need to assist the adult care providers so that they know how best to treat the patients with sickle cell disease.
It's just nice to have a good group of friends that really understands. Because some days you're by yourself, and some days no one can help you at all. You have to fight it by yourself, and to be able to have a support group that just understands you, it's really a blessing. Taking pictures for me is kind of like a tradition I do on my birthday. It makes me feel loved. I do not want to be defined by my illness. Just not someone, that's sick all the time or has this disease. I want to be someone, that makes change. Just an overall amazing leader in person.
So one of the things that I think is most important for sharing that video is just to share with you how our kids want to have a normal life, whatever normal means, right? They want to not be treated differently because of the sickle cell disease. They're not asking for any special favors or anything. They want to be normal teenagers and normal children. At the same time, we have to teach them that they have to advocate for themselves. They have to take care of themselves to have that normal life that they're looking for. And the advocacy continues after high school. Again, vocational rehabilitation services are available, and disability support services at the college level. I find that our kiddos do not take advantage of that as they should, and so they are not completing college like we would like to see. So again, I could talk all day, so let's just answer any questions that you guys may have. So I want to put, before I stop sharing my screen, I do want to give you my contact information in case you think of questions later. Emailing me is probably going to be the best way to get a response quickly because we're still not in the office consistently.
All right, thank you, Dr. Hamilton. So we do have questions. We're going to get on those. So I wanted to go back to that other question that you said that you would circle back. And so it was, how would you navigate a conversation with the school team concerning a toddler's need for constant hydration and specialized nutrition?
Right. So it's the same as you would for an older kid. And I think what's great about it is that if you start at the toddler stage, then you can continue, you get the practice and can continue that throughout their education career. Contact the school, whether it's daycare, pre-K. I've even gone to in-home daycares to provide information about sickle cell disease. So we want to educate them. If your medical providers don't have brochures, again, there's some information on the St. Jude website that you could share with them about sickle cell disease. And you have to talk to them about your child. You know, I know the sickle cell information, but you know your child, right? Like you're the expert on your child. So schedule a meeting or schedule a time to talk to them, provide them the sickle cell information. And because a toddler may not be great at expressing themselves, I say that, but crying is very great, right? It gets the job done. But you definitely should communicate with the school officials to tell them what to look for, to tell them how to contact you when they have uncertainties about anything. So again, the communication and the education are going to be super important.
This is from the Q&A from Felicia. My son had an IEP in high school. How can he use it in the fall for college?
So with an IEP, there are two routes. One route allows the student to actually get a diploma, and one route allows a student to get a certificate of completion. So it depends on which of those he obtained. If he got a diploma, he could apply for college like any other student, and he should definitely take advantage of the disability support services. If he got a certificate of completion, some colleges have some life skills programs that he could still possibly qualify for and live on campus and have an entire college experience. So depending on which route or depending on which of those he obtained will kind of steer the direction for what happens after that. But contact your local college, contact the college that he's interested in and ask more questions there. They can tell you specifically what services would be available to him.
And I just want to add to that briefly. I 100% agree with Dr. Hamilton contacting the disability services for the specific school that your child is interested in attending, but also signing up for support services in general early. is going to be something that's important. So, you know, a lot of people go into college and they're like, let me just see how it goes. You know, I want to just give it a try without any supports. That's incorrect. Sign up on day 2, because when you go to sign up right before or right after that big test, every single tutor is going to be booked. Every other student in college is already going to be in line, and you're not going to get the help that you need. So sign up early. And then if you don't need the services, great. But if you do, you already have signed up. So that's it.
Yeah. You're absolutely right. I encourage them to sign up for disability support services when you go for orientation. When you get your ID made, go ahead and go. And because there is also a process, they have to get paperwork done, you know. So yeah, you don't want to delay the services that you're going to get. And Dr. Land, again, you hit the nail on the head. I say it's like insurance. Hopefully you don't need it, but you want to have it in place. So thank you for reminding me to say that.
Thank you, ladies. Okay, the next one is in the chat. Are silent infarcts always diagnosed? By this, I mean, is there a way that this can be missed, or if someone has one, is there evidence left that a child has suffered a silent infarct?
So I can take this. And again, Dr. Rowley, Dr. Hamilton, if you have more to add, please feel free. So silent infarcts, based on their name, can be missed, right? So they don't occur with any of those acute symptoms that you typically see with stroke. So you don't have that difficulty with talking. You don't necessarily have that weakness of one side of your face or your body. And so they typically get diagnosed if possibly if you're having an MRI for some other reason, or if you're having some difficulties with processing, attention, behavior, then someone may get an MRI, and these are diagnosed kind of that way. So they can be missed on MRIs. Your typical clinical MRI, while very good, has certain, I guess, slice thicknesses. So it's looking at your brain in sections. And so it's looking at certain thicknesses, 0.5 millimeter to a centimeter. And so it can be missed if the infarct is so small that it's not getting picked up on the slices. There's also a certain resolution to the MRIs, the clinical MRIs. And so that can also mean that these silent infarcts can be missed. And so some of the work that we're doing at Kennedy Krieger is actually looking at if we should be doing more specialized MRIs in patients with sickle cell disease to really look where we know these lesions are occurring. And that's something that is done, like, for example, in children with epilepsy, with seizures, they can sometimes get specialized MRIs where they look at the parts of the brain that are associated with seizures. So we're trying to decide if that's something we should be doing for our sickle cell patients as well. The other part of things is that sometimes silent infarcts can go away. So they can be present on one MRI and then not show up on another one, or not show up on future ones. So there's not always evidence left that a child has had a silent cerebral infarct if you don't do it at the right time. So.
Oh, okay. Thank you. The this question comes from Jamie. Can you talk about how to go about hiring an advocate for school meetings? How do you find one? What should you look for? How much should you expect to pay? Dr. Hamilton?
I knew you were going to call my name. And I do not know the answers to that. So again, our services are provided in the hospital. We're hospital-based and we're paid by the hospital. And you know, I do think that it could get a little pricey to hire an advocate, but I also say that you are your child's first advocate and can be their best advocate. So it's about learning all that you can learn, and Rights Law, that's WRIGHTS Law, and actually I'll put that in the chat. They are a great source for learning about IEPs. They do training for parents. They do conferences. They put out books, lots of great information. A lot of what I've learned came from the Rights Law Group. They're two education lawyers. going to our website, again, there's great information there, and just really looking in your, looking locally for resources. It doesn't have to be an expert. It just has to be, I think, somebody who's willing to go to bat for your child and who has some knowledge. And when you work together with what you know and what they know, I think, again, you can get to what's best for your child.
I do want to add, though, that there are some CBOs. So when you were speaking, I realized that unless the child is part of a children's hospital, whether it's St. Jude's, whether it's CHLA, Children's Hospital LA, Rady's Children in San Diego, or what have you, these services are outside. A person who's not part of that hospital cannot access those services. So I would recommend that you then turn to your community-based organization. So for instance, for us, like here, Cayenne Wellness Center, we actually have social workers, we have your community health worker, but we also work with and partner with people in the community. So at least here in California, we actually work with a person who is an expert with navigating, working with the schools, getting the 504, etc. So if you're in California and you have difficulty or you would like to hire an advocate for school meetings, what have you, that can be done. So I would actually, if you're outside of your children's hospital, you're not part of that, then I would look for the sickle cell CBO in your area, and then they can probably help you navigate that landscape of locating an advocate for school meetings.
And I will just add that in Maryland, one of the places that I go to is actually a Parents of Children with Disabilities community organization. It's called Parents Place of Maryland, and they have educational advocates that will help the parent, teach the parent about the process and help them advocate for their child. So 100% agree with community-based organizations, and I'll put that link in the chat.
Thank you. All right, there's another question that was following the initial question about, I think, the silent infarct. This is from Michelle. I have the problem with always reminding the teachers that my daughter 504 is on file and should be followed. Even when she is in the hospital for 2 weeks or missed days due to pain crises and or appointments, I would inform them and send a copy of doctor's note, and she would have so much work to make up. But her 504 states that teachers will accept 75% of work and base work on quality, not quantity, and assignments will be graded on quality. But I worked with her to catch up on missed work, and I don't feel as though the 504 was working, and had to remind teachers often of this. And I basically had to do this on Friday, which was to email each teacher and remind them of her 504 and that the alternative teaching strategy listed in her 504 needed to be implemented. How can I make sure that the 504 works when she goes to 7th grade?
I'm so sorry that that happened to you and to her. You know, that's unfortunate. But I think it brings up 2 points. Number one is that you do want to make sure that when you have the 504 plan meeting, that everybody's at the table, you know, so that they understand the importance of what it is. And one thing that I did not mention is that each teacher has to sign off on the 504 plan, sign off agreeing to doing whatever is put in that 504 plan. So if it's then a legal document. And so if they're not following the plan at that point, they're breaking the law. Typically, what we like to happen, again, because myself and you as the parent, you know, we walk away, your child is the one who has to be with this teacher every day. So you really want to work hard to resolve it in a way that it's not going to affect the relationship between the child and her teacher. the fact that you had to remind them weekly, and I don't know if it's just one in particular or several that you had to remind weekly or repeatedly, it's a problem. So I would go to the school principal, the person that's over that person. That would be my first step, and have a conversation with him or her, about the legalities of the document, and they're not following that. And if it wasn't resolved in the building, at the building level, then I go to the district office and kind of work my way up that way. Again, communication. Sometimes a teacher, I've seen cases where the teacher came in later in the year after the 504 plan had already been developed, and they never got a copy, or maybe they didn't understand what it was that was expected of them. So, and again too, as I stated earlier, I would definitely communicate those concerns in writing, so that you have a paper trail in case you have to move up the ladder, and in case you get to the point of even going to your regional civil rights office. So try to resolve it with the teacher, maybe remind her once or twice in writing even. Maybe even call a second meeting. I think I mentioned that parents have the power. So parents have the power to call meetings. And when you call a meeting, they have to respond. So you can say that you want to update the 504 plan. As a matter of fact, if you do a 504 plan today and you go, your child goes to school on Monday and it's not working for them, on Monday, you can call another 504 plan meeting. They have to modify the 504 plan. You do a second one on Monday and you're still not satisfied, Friday, you can do a third meeting. There's no cap on the number of meetings that you have. They have to respond by law to your concerns.
And I just want to add, thank you for that. Unfortunately, there are times that it does have to get pumped up, and so on occasion, we've assisted families to where we had to suggest an attorney, and then they had to move it up, and of course, the family won. So it behooves the school to actually follow through to avoid having to get to this, go through the motions and, go through all the legalities. But as Dr. Hamilton stated, it's best and it's in their best interest to work with you and to to abide by the plan. So for whatever reasons why it's not, we never have any idea why. And some persons they allow the legality route to take place for whatever the reason. Doesn't happen often. And so Dr. Hamilton, you understand that that does happen from time to time, and which could be avoided for whatever reason why it's not. So just note that you do have that route as well once you've exhausted everything else. We'll take another question from the chat and then go back to the Q&A. This is from Chris. Are private schools also required to abide by 504 and IEP? Our son is 4 years old and we have chosen to homeschool till kindergarten. Are there any resources that can help us with homeschooling through our public school district?
So that's a good question. It depends. So some private schools get federal funds. If they get federal funds, then they, by law, have to provide these services. If they don't get any federal funds, if it's all paid by their endowments or by personal tuition, then they don't have to follow these laws. And then you mentioned homeschool. So let me make a distinction too between homeschool and homebound. Homebound services mean that a child is registered in the local school district, and then the school is providing one of their teachers to go to the home or I've even seen them come to the hospital to work with that child. That's homebound. Homebound is the school's responsibility. Homeschool is a parental responsibility. And so I've seen some online programs. The jury's still out about how well those kids are performing on achievement tests. And I will also say, I've seen cases where kids will go out to go to homeschool programs, and when they try to come back to the local schools, they have to test. And sometimes they test back to the grade that they were in when they left the system. So if you decide to go homeschool route, do your homework. Make sure it's an accredited program. Make sure that your state Department of Education is going to recognize the work that your child does so that they are promoted.
This is from our Q&A from Kiran. Do silent infarcts occur primarily in children, or do they also affect adults?
Silent infarcts occur in both children and adults. So while they're not uncommon in either children or adults. So I believe the rates are like 25% of children with SS, S beta null type thalassemia, sickle cell disease can have silent infarcts by the age of 6. And then it goes up to 33% by the age of 14, I believe. And then it goes up from there for the age of 21, and so on and so on. And so yes, adults can certainly have silent cerebral infarcts. I believe the latest sickle cell guidelines that came out last year recommend that adults with SS and S beta null thalassemia have at least one MRI to screen for silent cerebral infarcts. For children, the recommendation is the same, but they recommend that they wait to get the MRI when they can do it without sedation or anesthesia. However, guidelines say one thing and insurance and providers say other things. So it's always important to talk to your doctor if you're having any cognitive concerns about yourself, any difficulties with attention, difficulties with memory. Things can get harder as you age, but if you have sickle cell disease, you really need to be aware of those changes and mention that to your hematologist, okay?
Thank you. Rochelle would like to have, this is for Dr. Hamilton, the title of the video. She likes to want to be able to share that. I've seen that particular video, but if you can share how she can, or maybe put in the chat, the link.
Sure, I will. Okay. But I'll tell you, I just Googled, well, I knew that it was out there. It was on YouTube. It's Shania's video, but I'll find the link and put it in the chat for you.
Thank you, dear. Okay. We already answered that question from Renisha. Do adults have silent infarcts? And yes, both children and adults. Okay, Chris says, are there any early toddler red flags to be aware of to determine if your child is experiencing or will experience frontal lobe issues?
I will try to answer this, but again, Dr. Rowley, Dr. Hamilton, please jump in if there's anything I miss. So in toddlers, both in toddlers with sickle cell disease as well as in toddlers without sickle cell disease, I would say the developmental sign that we look for that indicates that that child may be having issues is actually language difficulties. So it basically depends on your child's age. If your child is under 1, then really the main thing that they're developing at that time are their gross motor skills. So learning to crawl, learning to sit up on their own, learning to walk. So when they're toddlers, which is usually between 2 to 4 years of age, language is what's developing at that time. And language is what gives us kind of the red flags for that age group. Sickle cell disease in particular, language difficulties have been associated with abnormal transcranial Doppler velocities. So those are the ultrasound tests that look at the speed at which your blood is going through the vessels in your brain and can determine if you're at risk for stroke. And so there have been studies showing that toddlers and early preschoolers with sickle cell disease who have abnormal transcranial Dopplers, meaning they're at increased risk for stroke, have specific language difficulties. And that's one of the most common things that we see in our patient group of young children with sickle cell disease. So that's the main thing that I would look for.
I will add that, yes, we start to get involved with I think I mentioned that we start to get involved at age 2. We introduce ourselves to families. And then at age 3, we give them a screener. And we are looking at their development of gross motor skills, their language development, receptive and expressive, their counting, their memory. So it's a short little screener, but we're looking for any abnormal development, any difficulty with language development. And so it's not to say that your child has a problem, but it's just that it's a concern that we want to make sure that we're paying attention to so that we can provide any interventions that they may need as early as we can.
Thank you. Next question. The person would like to know about neuropsychological tests for students with sickle cell disease.
Okay, I think this is in reference to Dr. Cannon's talk, which was the first seminar. And just so you guys know, the seminars are available on the Cayenne Wellness website if you want to go back and look at them. So basically, neuropsychological tests are, so psychological tests are what the school will provide. Neuropsychological tests are really someone who has additional training in neuroanatomy and brain development. And so they provide even more comprehensive testing and targeted testing. Usually done privately, can be done through hospitals, but can also be done by private neuropsychologists. What we do for our patients with sickle cell disease is we start with screening tests. So we look at their general cognition, their general language skills. We look at their general academic skills in math and reading. And if we see anything concerning or the parent reports things that are concerning, then they receive full neuropsychological testing at that point in time. And we can really target that testing based on the concerns, but we do like to do at least one kind of global comprehensive evaluation for these patients to really make sure that we look at all things. And that's important because we also want to advise the family about the child's strengths, not just the weaknesses, but the strengths. How do they learn best? What environment is good for them to learn in? And so that's part of why we do it. So if you're looking for a neuropsychologist, Google is always a good resource to find someone local. If you want to contact me, I can try to locate someone in your area as well. I know that Children's Hospital of Los Angeles definitely has neuropsychologists as well as other local hospitals. And again, your community-based organizations may also be able to connect you.
Thank you. And we do have Shania's story in the chat. And so at this time, we do want to see if there's any other questions. Either, I don't see any more in the Q&A, but if you have other questions, and or you can also raise your hand. And if you'd like to be able to share and or ask a question. I think that they're waiting for people to form their questions. This has been awesome, as always. This has been, we do have a hand raised. If I can find that person. There we go. Okay, you can unmute yourself.
Hi, thank you. Well, I'm listening from Trinidad in the Caribbean. It's been very informative and interesting. I have a question for Dr. Lance. I know she mentioned earlier that younger patients or children who might have experienced strokes have a better chance of recovery, right? But at what age does that advantage diminish or begin to disappear per se?
All right, great question. So when we're talking about brain plasticity, which is the ability of the brain to recover from injury, in children, usually that ability starts to diminish between like 3 and 5 years of age. However, and that there's always caveats. It still depends on how severe the injury is, because there may be damage to the brain that is so severe that the child does not recover. And it also depends on the location of the injury, because the location of the injury may cause deficits that aren't able to basically grow new pathways, grow new neurons, and reconnect to different parts of the brain to still work. Now, the other part of this is that that doesn't mean that people above 5 years of age don't recover. Everyone recovers some function, and usually we say when children or adults are about 1 to 2 years out from brain injury, that may be the point at which recovery significantly slows down. But it's really important in those years, the time period, the critical time period after the injury, to really be doing rehab, to really follow your doctor's recommendations, and to really push yourself to improve as much as possible in those critical early periods, no matter what age you are. That's what we would recommend.
Thank you. Any other questions and or comments, stories? Okay, so this is a good opportunity. Well, as I was saying earlier, as I mentioned at the beginning, this is actually part 3 and the last of our brain series. As Dr. Lambs mentioned, part 1, 2, and this will be on our website. So you'll be able to start from the beginning and review. It's been just a lot of information that you might want to be able to go back to be able to just kind of refresh. There's something for everyone, whether you're a parent and or an adult and or a young person, a student. So you may want to be able to go back. We did want to put up as Ms. Gilliam had done, want to actually put up a post test. Let's see how much you guys have been able to hold in terms of information. So let's see. The first one is having sickle cell disease. Oh, I think we did that one, but having sickle cell disease qualifies you for an IEP, true or false? And so she did go over that. So hopefully we get 100%. So if everyone can answer that one, number 1. Number 2, who takes part in the school planning meeting to share information about the medical needs? And so is it the student A, is it the caregiver B, is it student and caregiver C, only the staff D? So, okay, I thought we had another post test as well, but.
If you keep going down, there are more questions.
Oh, okay, there are. Thank you. Sorry, I didn't scroll. All right, number 3. Which law provides for protection of civil rights of students with chronic illnesses? Is it the Rehabilitation Act of 73? Is it the Individuals with Disability Education Act? There you guys go. Voters' Right Act or COVID Recovery Act? Okay, so we already have our answers for number 1. So I'm going to kind of, I think what she wrote down, if I'm not mistaken, she put down that that was false. So having sickle cell disease does not qualify you for an IEP necessarily. So that one actually was false, and she actually gave the reason. Number 2, C is correct.
People are still taking it, I think. It's still in progress.
Oh, they are? Okay, sorry.
Watching
Okay,
the
now
answers
you're gonna put the right answer, huh?
Yeah.
Okay, number 3. Which law provides for protection of civil rights of students with chronic illness? And so we'll wait for you guys to answer that. This would be Dr. Hamilton. Let me read number 4. Which plan provides for medical accommodations at schools? Is it the IEP, the 504, the individualized health plan, or all of the above? And then we'll go back and see how you guys did. Number 5, what accommodations could be provided by having a current educational plan in place? Frequent water and bathroom breaks, extended time to complete assignments, extra set of books at home, all of the above. Number 6, who should participate in the school meeting? Parents and students, teachers, school nurse, school counselor, psychologist, principal, assistant principal, all of the above. And I'll read number 7 and then we'll go back with Dr. Hamilton's questions. Parents have a right to request a 504 plan IEP meeting for their child only once per year. True or false? All right, let's go back to then number 3. So which law provides for protection of civil rights of students with chronic illnesses? Dr. Hamilton?
That is the Rehabilitation Act of 1973.
Okay. So we got
And
about
remember that's the law that provides for the 504 plan.
Thank you. Okay, number 4. Which plan provides for medical accommodations at schools?
What are my options again?
IEP, 504, IHP, or all of the above?
All of the above. I think I wanted to say which one provides only for medical accommodations,
Yeah.
but yes, all of those will include medical accommodations. The IHP or the health plan does not provide any academic accommodations.
Thank you. Number 5, what accommodations could be provided by having a current educational plan in place? Frequent water and bathroom breaks, extended time to complete assignments, extra set of books, or all of the above?
All of the above, everything.
About 92%. Number 6, who should participate in the school meeting? Parents and students, teachers only, schools, counselor, psychologist, principal, or all of the above?
All of the above. We want everybody who's involved with the child to be involved in the meeting too.
Excellent. We have 100% there. And the last one, number 7.
Good job, y'all.
Parents have a right to request a 504 plan IEP meeting for their child only once per year. True or false?
That's going to be false. You can request it as much as you'd like.
Okay.
And I will encourage, let me just add too, I know that sometimes we get emotional and we get upset. It really behooves you to request and to do these things as politely as possible, even when they are wrong. And sometimes they are, and sometimes it's just because they don't know, and sometimes, it's because of different attitudes. But I just encourage you to try to be respectful and to try to do it in a nice way. I think the response will be different for you and for your child.
Mm-hmm. Okay, so that includes concludes post-test. And if there are any other questions, but I would like to, Dr. Hamilton, thank you. Excellent, excellent. As Dr. Lansnell, when I say that you're going to be called upon, you're going to be called upon. And so because it's it's important that everyone has access. And if you're not part of a children's hospital, people still need access. So that's what we're going to do here. We do have people in place, but I want to really bump it up. And so count on the fact that we're going to be calling upon you.
I'd love to be a part of it. Thank you. Thank you for that.
You're welcome. And so Golda and I, Dr. Lance, you are a phenomenal woman. You're quite excellent. And I want people to know this. I never forget when we first, when I first invited Dr. Lance, which was several years ago, and when she said, "Why me?" I was kind of, hello. When I typed in for the best person to talk about the brain and neurology and neurodevelopment, it was obvious that it was Dr. Ebony Lance. And so since then, we've had her for every seminar. It's because of her that we actually began these mini seminars, which are actually very popular now. Um, and she's being requested at many of the other sickle cell seminars. So Dr. Lance, seriously, you are a phenomenal person, awesome researcher, very, very dedicated. So we're very thankful because we really could not have done this mini seminar without you. It just wouldn't exist. And so the number of people who have registered, who are on Facebook, who are here, who are actually looking at the pre-records, that are on the website says a whole lot about your contribution. So thank you for being part of this.
Thank you. It really is my honor. And thank you for continuing to address my imposter syndrome. I'm working on it. I really try to stay off the radar and make sure that my patients and their families get the help that they need. But I recognize that advocacy is important and that teaching patients, families, how to advocate for themselves and their children is also important. So I'm honored to be a part of this work. So thank you.
We do have a last question. If a child has had an undiagnosed silent infarct, will there be evidence of it as they age? So but we can answer that again.
Sure. So the answer is yes and no. So the child can have a silent infarct that shows up on MRI and that has associated clinical symptoms. So they can have difficulties with attention, difficulties with memory, possibly even processing speed issues as well. As they get older, those deficits could get worse. They could stay the same or they could go away. And then the same thing is true with the MRIs. So the MRIs, the silent infarct lesions are not always visible. So they may go away over time. So it really just depends, unfortunately. But even if the lesion itself disappears, that doesn't mean the child never had it. That doesn't mean that the symptoms associated with it disappear as well. It was there, it was picked up on MRI at some point. And so that diagnosis remains. Thanks.
Thank you. So that brings us to our time. And so unless there are any other final questions or comments, I would like for you all to please join me in thanking Dr. Lance as well as Dr. Hamilton for their time. This has, again, been truly amazing. We're very excited. This went off so well. And so we do want you to join us for mental health. We still have a couple of talks for mental health as well as sleep. We're already planning 2022. And so if you actually have some ideas and thoughts, feel free to email us those because this is all patient directed. It's whatever you all want to hear is what we're actually providing. All right. I don't see any other hands raised or questions. So I think we're going to officially adjourn at this time. And again, thank you for all that you guys do where you're located. So thank you. All right, everyone. So we are going
And
to.
lastly, just please fill out our post survey so we can keep making better, bigger, more amazing mini seminars for you guys. Thank you.
And thanks to our third speaker as well, Ms. Gilliams, who couldn't be here today.
Oh, yes. Thank you. Thank you. So I'm going to Golda and I will hang out. We know that our speakers have dedicated their Saturday to us, but they're on the East Coast, so it's actually 4:30. So we want them to continue on with their afternoon. But we do linger longer. We will unmute everyone at this time if you wanted to be able to just kind of chat. You know, if this was in person, we would be able to just kind of, you know, hang out a little bit. So we'll hang out. The speakers, you guys are willing to hang out as well, but we are officially adjourned. So we're going to actually press the stop recording and allow